Hello, and welcome to Eating Disorders 101 for Clinicians, a practical foundation to better recognize eating disorders in practice. My name is Emma Klinkingbeard. I am the clinical director at the Tasty Balance. A little bit about me. I have been a registered dietitian for the last 7-ish years, and about 5 of them have been spent with eating disorders and disordered eating. I've really spent my career guiding individuals towards a healthier, more balanced relationship with food in their bodies and movement. The Tasty Balance is a Midwest-based group of registered dietitians that offer personalized nutrition counseling and intuitive eating, gut health, and eating disorder recovery. As a practice, we believe that compassionate, individualized support creates not just better health outcomes, but more sustainable well-being and trust in one's own body. So, a little bit about this presentation and what we will cover today. This presentation is really meant to be a guide and a kind of overview on eating disorders and what you may spot in your clinic or where you are practicing. So, we'll go through some of the clinical features of disordered eating and eating disorders. If we do spot some signs or symptoms or behavioral concerns, how to start the conversation with the patient, then moving to screening and diagnostic tests, special considerations, and then we'll finish out with some resources. So starting off with clinical features, supporting patients does begin with recognizing the disordered eating patterns or physical signs or symptoms that may pop up for them. So in general, there are a lot of different physical signs and symptoms that can be an indication that there is disordered eating or an eating disorder leading to malnutrition. In general, there will be maybe weight fluctuation, so that can be loss or gain or even just kind of yo-yoing up and down. Signs and symptoms of malnutrition, so maybe there's muscle loss, fatigue, lethargy. Maybe you see some marked indications of kind of muscle wasting on an adolescent or pediatric patient. Any sort of slows in their growth progressions or even delayed pubertal progression. Some things such as weakness, cold intolerance, dizziness, muscle cramping. Some patients may experience things like hot flashes or sweating episodes as well. So that's kind of the general overview. More specifically into areas such as like oral dental, you may notice kind of poor dentition, more cavities or dental caries, dental erosion, or even some parotid enlargement that can be indications of purging. Cardiorespiratory, so there may be chest pain, arrhythmias, shortness of breath, or edema, which can be indications of malnutrition or misuse of diuretics. Impaired or dermatologic. That can be things such as lanugo, hair loss. Maybe they have like yellow nails or brittle nails. A Russell sign, so the calluses on the back of the hand, that can be indications of purging. Endocrine dysfunction, so this can be amenorrhea or menstrual irregularity, infertility, loss of libido, as well as increased risk for fractures because of low bone mineral density. Gastrointestinal issues is really also common in malnutrition and individuals with eating disorders. So this may be reflux, this may be, IBS symptoms, this may be constipation or rectal prolapse, early satiety, delayed gastric emptying. Those are really common, especially in malnutrition. And then finally, some neuropsychiatric things to look out for. So poor memory, memory loss, poor concentration, oftentimes insomnia or difficulty falling asleep or staying asleep. A lot of times eating disorders can be connected to depression or anxiety or obsessive behavior, as well as self-harm or suicidality. So then next is kind of looking at behavioral signs and symptoms. These are things that as you talk with your client, they may be kind of reporting some of these things to you, or even parents may be reporting some of these things to you. So all eating disorders may include some or all of these symptoms. So isolation or withdrawal from usual activities or from meal times or eating times. So food noise, that can be a lot of concerns around, label reading, or maybe they're concerned about eating good foods versus bad foods. They're concerned about what they're going to eat. A lot of high levels of shame, guilt, disgust, or embarrassment around their body or around food. There may be more comparison to others' bodies or a distorted body image overall. Defensiveness when eating behavior is addressed. And then also feeling out of control. So, like I said, with the food noise, maybe they're thinking about food all the time. They may also be feeling out of control around how much they're eating, what they're eating, when they're eating. And then self-esteem and self-worth also is tied heavily to body shape and weight, especially in clients with eating disorders. So now we're going to go zoom in a little bit and look at specifically the different types of eating disorders. So starting over with binge eating disorder, the prevalence of binge eating disorders in women, so 3.5% of women in their lifetime will have binge eating disorder, and about 2% of men will have binge eating disorder at some point in their life. Binge eating disorder is defined by eating a large amount of food in a short period of time. A lot of it also is tied to feeling a lack of control around food, eating past fullness frequently, eating more rapidly than normal, eating until uncomfortably full. It also can be, you can see hiding or hoarding food. A lot of times with adolescent or pediatric clients, parents will find wrappers in the bedroom, or food will disappear and then kind of be found later. And then binge eating disorder behaviors may also be the result of not eating enough food, so falling into a restrict binge cycle. You may see a patient that goes long periods of time without eating and then they will binge. Then moving over to anorexia. So anorexia is defined by an obsession and rigidity with food, weight, shape, size, calories, dieting, and or exercise. And these patients have an intense fear of gaining weight and oftentimes are trying to lose weight. That can lead to frequent weighing or body checking behaviors, as well as calorie restriction or overexercise. They oftentimes will deny hunger cues to lose weight. And a lot of times when they are losing weight or are getting extremely sick and malnourished, a lack of insight can lead to more severe conditions or cases. Oftentimes with anorexia, there's also withdrawal from usual activities with friends and activities, and avoidance of public eating. We found that 50 to 80% of anorexia nervosa risk is genetic, and the median age for the onset of anorexia is around 12 years old. So really at that start of the puberty, especially in a lot of female patients. Moving on to bulimia nervosa. So bulimia is consuming large amounts of food in a short period of time, followed by the use of compensatory behaviors via laxative, diuretics, enemas, self-induced vomiting, excessive exercise, or diet pills. So it is a binging behavior followed by a purging behavior. A lot of times you will also see, restricting or fasting with clients that have bulimia. Chewing and spitting is pretty common, which can lead to a lot of cavities and dentition issues. And then also these patients do have a fear of gaining weight as well. And then finally, avoidant restrictive food intake disorder, ARFID for short. This diagnosis tends to be more common in childhood and affects more male than female patients. It is also associated or seen pretty commonly in the neurodivergent population, or those living with a psychiatric comorbidity such as anxiety or OCD. This population tends to be avoidant of certain foods or food groups due to sensory sensitivity and fear of those foods. So they are restrictive due to a lack of interest or just extreme pickiness. This population or this diagnosis, they don't have any concerns around body image or weight gain. They tend to be on the, malnourished side just due to the extreme fear or pickiness around food. And it is more common in children and adolescents. So that's something as well to look out for in your pediatric clients. So if we are assessing a patient and we're concerned about some eating behaviors or some things that maybe we've seen with their growth, maybe we're seeing some signs or symptoms, then we would want to start the conversation. So when we're starting the conversation, small language shifts can open really meaningful dialogue and create a safe space for a patient to be really honest about what they may be going through. You can help your patients by keeping some of these tips in mind. So being really thoughtful about your approach and your language when you're starting the conversation, and even just when you're practicing with these patients. Really being considerate of their comfort and respecting their boundaries around discussions around weight or food. Continuing to educate yourself around eating disorders and familiarizing yourself with resources or providers that specialize in the field to kind of provide their insight into maybe what might be going on with the patient or someone that you can refer this patient to if you're having difficulty really understanding what's happening. And then also knowing that many commonly used words or phrases in the medical field may have unintended negative impact on these patients. So some swaps that we can make, especially when we are working one-on-one with a client, is instead of saying things like clean eating, healthy eating, good or bad foods, trying something like eat a variety of foods for energy, nourishment, and enjoyment. So really trying to take a more neutral approach versus moralizing food choices. Instead of saying things such as move more, get X amount of steps per day, exercise X amount of minutes per week, trying things such as, body size, shape, and weight vary from person to person, as do food and exercise needs. So have you been able to find the balance of movement that works for you? Instead of labeling individuals' body size by overweight or obese or thin or skinny, saying things such as larger body or higher weight, smaller body or lower weight. And then finally, like if a client has lost or gained weight since your last visit, not commenting on weight at all for anyone, and asking them, have you noticed any changes since our last visit that you would like to discuss? This is not just for clients with eating disorders, but for probably the general population, and trying to create a more neutral approach to discussions around weight and around food. So it's some informal screening questions that you can ask if you are unsure if there's any sort of disordered eating patterns or eating issues. Asking, do you currently suffer with or have you ever suffered from an eating disorder? Has any of your family members ever suffered from an eating disorder? Are you dissatisfied with your eating patterns? Do you ever eat in secret, or does your weight affect the way you feel about yourself? If any of these answers are yes to these questions, that is classified as abnormal and should result in further assessment. So going into more formal and diagnostic tests, once we've done some of those informal screening and had some of this dialogue, turning that into a direction with validated measures. So when we are assessing a client and wanting to identify how we need to go about their care, we want to identify, do we have an eating disorder, disordered eating present? How stable are they, and where can we refer them? In identifying, one formal screening tool that you can use is the SCOFF screening assessment. S, do you make yourself sick because you feel uncomfortably full? C, do you worry you have lost control over how much you eat? O, have you recently lost more than 1 stone in a 3-month period? F, do you believe yourself to be fat when others are too thin? F, would you say food dominates your life? 2 or more positive responses on this short screening assessment indicates a possible eating disorder, disordered eating, and should prompt a referral. Another screening assessment that you can do is the EAT 26, and this is the most widely used standardized self-report measure of symptoms and concerns for eating disorders. So this can be used in a non-clinical as well as clinical setting, and it's not doesn't specifically have to be in a clinical setting that is focused on eating disorders. It is particularly useful in assessing for eating disorder risk, and then a score of 20 or more should be referred to a professional for treatment of disordered eating or eating disorder. So once we've screened, we do want to do some diagnostic tests. So looking at lab values and an EKG. So basic tests to consider would be the CBC, CMP, and electrocardiogram. We really want to monitor for some of these kind of electrolytes, as well as just glucose levels, kidney function. A lot of times they are off in clients with eating disorders, either ranging on the low side for things like glucose, sodium, potassium chloride, and then for kidney function, the blood bicarbonate, BUN, and creatinine tend to be on the high side just due to malnutrition and dehydration. Additionally, liver enzymes tend to be high in clients with malnutrition. For the EKG, we do want to look for bradycardia and other arrhythmias. It's fairly common in clients who are athletes who also have eating disorders to be misdiagnosed as just having kind of an athlete heart, but looking for specifically any arrhythmias with those clients can be really important for their safety and making sure that they are getting the care that they need if they are under eating or engaging in disordered eating behaviors. Some other diagnostic tests to look at. So leptin, that tends to be low in malnutrition. Thyroid, so TSH, T4, T3, all tend to be low. Even if they are metabolically at a healthy weight, a lot of times these can be indications of malnutrition or disordered eating patterns. LH, FSH, estradiol, testosterone all tend to be on the low side or even low normal. And then ESR and prealbumin are also ones that are indications of malnutrition. Prealbumin is only reflective of the past 72 hours, so that's not necessarily the best measure for looking at chronic malnutrition. So once we have looked at some of those diagnostic tests, we want to look at how stable is this patient. Eating disorders have the second highest mortality rate of any mental illness. So early intervention can make a full recovery possible, especially in our younger patients. And with treatment, mortality rates fall from 20% to 2 to 3%. So we know that early intervention and treatment do work for these clients, especially in nutritionally rehabilitating them. So these are the various levels of care. The highest level of care obviously is our inpatient, so that's going to be 24-hour care, a lot of monitoring to stabilize lab values. Once they have been able to stabilize, then you would move them more to that residential level of care, which is still 24-hour care. However, they are not receiving as much daily monitoring of lab values and their risk of refeeding or having any sort of acute conditions arise from their malnutrition. That risk has gone down. Once they have done some time in the residential level care, oftentimes the step down is to partial hospitalization, which is anywhere from 6 to 8 hours per day. At that point, they can move to intensive outpatients, which can be anywhere from 3 hours per day to 3 to 9 hours per week. And then the lowest level of care is outpatient. Depending on when you are evaluating the patient and the severity, that's going to determine what level of care they're going to go into and how stable they are medically. If you have a patient who is fairly medically stable, they can just go into the outpatient level of care and be referred to an outpatient eating disorder dietitian or eating disorder therapist for further evaluation on kind of addressing the eating concerns. So when we do refer them out, we do want to make sure that they have a team of medical providers behind them to help support them through their recovery. So Having a primary care physician, medical provider, or an adolescent medicine doctor is really important for continued follow-up and monitoring vitals, labs, growth charts, and menstrual health. An eating disorder informed, eating disorder trained therapist, as well as an eating disorder trained dietitian. Those may be people that they're seeing on a weekly basis to help work on intervention to promote their recovery. A psychiatrist will also be really important for medication management. And then speech language pathologist and occupational therapy can also be really beneficial for clients, just depending on their various needs. So, and then for follow-up and monitoring, coordinating all together as a team on their progress and how often they need to be following up with these different providers to help facilitate their health and recovery. Some special considerations. So when a client is going through their treatment, or maybe you do have concerns around disordered eating or an eating disorder pattern, it's recommended that we only take weight when absolutely necessary. A lot of times in outpatient levels of care, the dietitian will be the one that's monitoring weight weekly and doing things such as blind weights. If you know that that is happening, my recommendation is that you just reach out to the other providers for that information if you are needing it, and avoiding taking weight when a client comes into a clinic. If you do need to weigh, consider doing blind weights or documenting as well as documenting without any comment or reaction, and then avoiding putting it on the patient portal or the after visit summary so that the client doesn't really have access to that information. This isn't necessarily necessary for clients who maybe are further along in their recovery. So just dependent on the client and what their needs are, and being very kind of considerate and respectful of those boundaries that they may set. Some special populations that I think are really important to address as well in the disordered eating and eating disorder realm. So adolescents are very high risk, especially around that puberty age. And then early and intentional intervention is really important for these patients for a full and sustainable recovery. So family-based treatment is often preferred with these patients to involve the family, involve the kind of home system in order to help promote a recovery for that client. BIPOC and LGBTQIA plus individuals do have higher barriers to care and are often diagnosed. There may be some medical distrust, or they may not report a lot of these behaviors due to cultural or just different concerns or issues. So these are ones also to kind of ask more inquisitive questions on things that they may be concerned about, or eating or body concerns. Males and gender diverse patients may have an atypical presentation. They may experience things such as body or muscle dysmorphia. They may not have concerns around weight loss just based on how they are using exercise, or if they are receiving any sort of hormone replacement therapy. So these are ones also to ask a lot more of those specific questions around eating or body concerns. And then finally, higher weight patients. So these patients also are often misdiagnosed or don't seek care for eating concerns due to weight bias and concerns that they will be discriminated against or not listened to by a healthcare professional. So these are ones, again, to be very cognizant of that vulnerability, and also asking some of the correct questions on if they have any concerns around their eating or their weight. I wanted to plug this in as well. We won't spend too much time on it, but the Health at Every Size framework I have found has been extremely beneficial for clients, not just ones with eating disorders, but in trying to adapt, working with clients around their health in a very with a lot of body diversity. So it really highlights shifting away from focusing on weight and a weight-centric approach to really addressing behavior change and celebrating body diversity to attain these desired health outcomes. So some of the Hayes principles is that healthcare is a human right for people of all sizes, including those at the highest end of the spectrum. Well-being, care, and healing are resources that are both collective and deeply personal. And care is fully provided only when free from anti-fat bias and offered with people of all sizes in mind. Just a little bit more information on that. The Hayes framework is a comprehensive guidance developed by the Association for Size Diversity and Health to assist healthcare providers in delivering ethical, inclusive, and effective care to individuals of all sizes. So a lot of their education, their materials, the resources that they put out are really addressing anti-fat bias, addressing systemic anti-fat bias, helping create clarity around provider roles and responsibilities, as well as tools that support well-being and healing without contributing to oppression that a patient might already be experiencing. So it's really, really addressing kind of compassionate care for all individuals. And then our resources. So some great resources that we have available to providers, but also patients. So the National Eating Disorder Association, National Center of Excellence for Eating Disorders, Academy of Eating Disorders, and then Association for Size Diversity and Health. All of these resources have both provider-facing and client-facing resources that are wonderful and just great depending on what a client is needing. And then these are some sources for this presentation. Thank you so much for listening. If you have any questions at all, please don't hesitate to reach out. You can reach out via phone, email, or just visit our website online. We also have some other free resources available, as well as some resources for purchase. Thank you so much.